Greetings, dear learners. In the last classes, we were learning the management of poisoning. In that, after finishing A, B, C, D, E of the immediate resuscitative measures, we discussed removal of unabsorbed poisons from the body. Under that, we learned that for the removal of unabsorbed poison from the body, we may perform decontamination according to the route of administration, like for inhaled poison, for injected poison, for contact poison, and ingested poisons. We apply different methods in different types of poisoning for the removal of unabsorbed poisons. For inhaled poison, the first step shall be to remove the patient into the fresh air. Then clear air passages, apply endotracheal intubation if necessary, then artificial respiration and oxygenation inhalation. If bronchospasm, then give aminophylline, inhaled beta-2 agonist, oral or parenteral corticosteroids. Diuretics if for to correct the pulmonary edema and in difficulty breathing, and monitor for the any respiratory distress, and in case of cough, evaluate for the respiratory tract infection, bronchitis and pneumonitis. Then for injected poison, the first and prime step shall be to reassure the patient or calm down the patient. Then manage ABCDE, then treat the shock, observe the patient for any allergic reaction, remove the sting. Local vasoconstriction is helpful by doing the injection of the adrenaline or applying the ice locally or immersing the part of the body into the cold water. Then the important thing is that tight ligature above the injection site, wound excision, sucking out of the poison with the mouth, or local neutralization of the poison with the chemicals is no more recommended and is obsolete now, and so it shall not be done. Then we learned for in the contact poison, if poison comes in contact with the eyes or the skin, then how to remove the unabsorbed poisons. For the here the role of the water or saline is very important. For the eye, irrigate the copiously with the saline or water for at least 15 to 20 minutes. Then in case of the chemical burns to the eye, place the face under the running water or in a shower while holding the eyelids open. Then transport the person to the hospital with the face immersed in the water, trying to not to inhale the water. Then for the cleaning the skin from the exposed chemical, the person should rinse with the cold water and then wash thoroughly with the non-germicidal soap. And then the corroded area shall be irrigated copiously with the water or saline for at least 15 minutes. Change the old clothes and use the only new and the clean clothes. Then for the ingested poisons removal, we learned the various methods available. That includes the emesis, that is the vomiting, then the gastric lavage, that is cleaning of the stomach wall, then the catharsis, that is the purgatives used cleaning through the anal defecation or diarrhea, then the whole bowel irrigation through the polyethylene glycol, that also cleans the whole of the intestinal mucosa. Then the endoscopic gastroscopy and surgical removal through the gastrotomy we learned. So through all this, we covered the step of the removal of unabsorbed poison from the body. So today we shall learn the third step in the broad guidelines of the management of the poisoning, that is removal of absorbed poison from the body. So for that, the following steps or methods are employed for the removal of absorbed poison from the body. These includes the diaphoretics, that is the increased sweating, the compounds that are causing sweating, enhanced renal excretion, then urine alkalinization, urine acidification, hemodialysis, peritoneal dialysis, hemoperfusion, hemofiltration, cardiopulmonary bypass, exchange transfusion, or intravenous lipid emulsion. Now think, what we were doing was the patient that came to us, we first stabilized the patient. Once the patient got stabilized, then the next step is to remove the unabsorbed poison from the body, that has not come into the systemic circulation. Now the poison has come into the systemic circulation. So from the systemic circulation, what all could be the method that can expedite the removal are applied under this chapter. So the diaphoretics, once it is in systemic circulation, so it will, by sweating, it will excrete out by the extra renal excretion that is done through the also through the urine alkalinization and acidification that we will learn now. Then hemodialysis, that is blood, we are filtering the blood through the hemodialysis, peritoneal dialysis, hemoperfusion or hemofiltration that is being done. Also the cardiopulmonary bypass is the same step, a type of the blood filtration. Then exchange transfusion is again the same, we are filtering the blood. Then the intravenous lipid emulsion is also a similar kind of things where the lipid soluble substance will be absorbed or excreted out easily. That will become, we will be learning all of them one by one. And another important is the activated charcoal is also used to remove the adsorbed poison from the body by its adsorbent property. But we will read the detail of it along with the antidote chapter. So coming now to the diaphoretics. Diaphoretics are the drug that cause sweating. This is not a very scientific or the very proven method of the removal of the absorbed poison from the body, and it is in the controversial that if it increase the poison elimination through the sweat. Common diaphoretics agent used are the alcohol, antipyretics, blankets also used to sweat and the remove cause the producing the sweating. Hot beverages, tea, coffee, milk, lemonade may cause the sweating, increase sweating. Hot water bottles, pilocarpine nitrate given 5 mg subcutaneously, salicylates, all these can cause the increase in the sweating from the body. Then the second step is the enhanced renal excretion. In the large amount of fluids are given in this method, that is also known as the forced diuresis, that a large amount of the fluid through the injection is given and the through the blood route is given. It is like the flowing the full of the bucket over the stairs and taking out all the dust and all the garbages from the stairs. So this is in a similar way that we are cleaning the blood by giving a lot of fluid, and so that the more of the thing it will be excrete out through the urine, and so it will be get out of the body. But there is a lot of danger with it, because the more the fluid you are giving to the body, other side effects like pulmonary edema and the cerebral edema, excess of fluid overload in the body may be there, and that is itself very dangerous and life threatening to the patient. So itself preferably be avoided or used very cautiously. So now coming to the urine alkalinization. In former times, the stress was more on increasing the urinary flow than on increasing the urinary pH. At that time, other terms like forced alkaline diuresis and alkaline diuresis were used. This procedure had disadvantage of fluid overload with other complications like the pulmonary edema and the cerebral edema. Currently, urine alkalinization is employed rather than the forced alkaline diuresis. The emphasis is on the urine pH manipulation rather than on the diuresis. Forced alkaline diuresis and the alkaline diuresis are now avoided. We already discussed there in the enhanced renal excretion that it is not of much benefit. So this urine alkalinization is very interesting to learn. The principle behind the urine alkalinization is that the uncharged ions can freely pass through the biological membranes, while the charged ions cannot. The normal process of the urine formation is that from this blood, the urine is filtered in the glomerulus through the Bowman's capsule, and this first step is the filtration of the blood forming the urine. And then this filtered blood goes to the proximal convoluted tubule then the loop of Henle and the distal convoluted tubule and the collecting ducts, and during this passing it gets reabsorbed, which is useful, and the unuseful things are again secreted. That is the third step. So the first step is the filtration, then the reabsorption of certain useful thing, and the further secretion of certain unuseful thing, and then it get finally excreted in form of urine. So with these steps, the urine formation occurs. Now when they are in the tubules, then at the time of absorption, reabsorption of the solutes, the uncharged ions are seen to be freely passing through the membranes, whereas charged ions are soluble and they will be excreted in the urine. So this principle is applied for the urine alkalinization. So suppose a toxic substance is there which is passing through this urine. If it will be in the unionized form, so it will be absorbed back. But if it will be in the ionized form, so it will not be absorbed back. So if we make the urine of either, if the substance, that poison is of alkali nature, then the poison will be more in the ionized form if that is in the urine is of acidic nature. So for the alkali compound, acidic urine is helpful to make it in the ionized form. For the acidic compound, the alkaline urine is good for making it in the ionized form. So in that condition, it will be excreted out easily. So by giving the compound that causes the urine alkalinization for the acidic compound will be helpful to excrete out the acidic drugs. This is the basic principle applied for the urine alkalinization. So if a poison molecule is in uncharged form, whatever molecules are filtered by the glomeruli would diffuse back in the system. Poison molecules in the charged form will be retained within the tubules. So you can learn from this chart that this is a chart for the lidocaine compound. Lidocaine is a weakly basic drug. It has the pK of around 7.8. So at the pK, the lidocaine is a concept that at pK the drug is 50% in the ionized and 50% in the unionized form. So if we increase the pH of its solute or this mixture, then it will be ionized form will decrease and non-ionized form will be increased. So if it is passing through the urine which is more of alkaline nature, so it will be more of in ionized, it will be more in non-ionized form. So it will not be excreted, but rather it will be absorbed. So if we decrease the pH of the mixture, so it will be more in the ionized form. That is, if we increase the acidity of the solution, so the lidocaine will be more in ionized form, so it will be excreted out easily. So you can better understand it now. So normally a drug is in the urine is in both ionized and non-ionized form. A pH of urine changes, the ratio between the two species changes. That is, if pH changes, so ratio of ionized and non-ionized form will change. At its pK, the drug is in the 50% ionized and 50% non-ionized form. An acidic drug would be more ionized in an alkaline urine, and the basic drug would be more ionized in the acidic urine. If we want an acidic drug not to cross the tubule, in order to increase its elimination, we must alkalinize the urine, and in the reverse, acidification should be done in cases of alkaline drugs. So this is the basic principle used for the urine alkalinization or urine acidification. So here that we can see that for the excretion of the lidocaine, we must decrease the pH of the urine, that is urine acidification shall be done. So the drugs or poison in which urine alkalinization is useful are the phenobarbital, salicylates, 2,4-dichlorphenoxyacetic acid, a herbicide widely used by the government to destroy the illegal poppy plants, Macoprops, a selective hormone type phenoxy herbicide. We will discuss them later when we will be discussing agriculture poison. For the chlorpropamide, diflunisal, fluoride, methotrexate and formate. For them, urine alkalinization is helpful. And in the similar lines, the normal pH of urine is the 6 and goal of urine alkalinization shall be that the pH to be increased more than 7.5, and the goal of urine acidification will be to decrease the pH of less than 5 or around 5. What is used for alkalinization is the sodium bicarbonate, that is given in the dose of 1 to 2 milliequivalent per kg for every 3 to 4 hours. And urine output should be measured. The normal urine output is the 1 milliliter per kg per hour. In case of urine alkalinization, this rate increases up to 3 to 6 milliliter per kg per hour. Contraindications for giving urine alkalinization is the congestive heart failure, renal failure and cerebral edema. Then in similar lines, the urine acidifications are done. For the drugs for which the urine acidification is useful is the phencyclidine. As we already talked that these drugs natures will be the basic in nature. So phencyclidine, amphetamine, methadone, cocaine, quinine, quinidine, sympathomimetics, strychnine, these are all drugs for which urine acidification is helpful. Then to achieve the urine acidification, intravenously ascorbic acid or ammonium chloride is given in the dose of 1 to 2 grams every 4 to 6 hourly. Then the hemodialysis. Hemodialysis is the method of removing metabolic wastes as well as free water from the blood when the kidneys are in failed condition. So we are very commonly knowing that for the renal failure patient, the person is being repeatedly exposed to the hemodialysis. So in case of the poison cases where the renal failure is there, in those cases hemodialysis is of benefit. Hemodialysis was first used in 1913 for the removal of salicylic acid in experimental poisoning. For the first time perhaps, this hemodialysis was used in the poisoning cases only. But it was not tried clinically until 1950 when it was used for the treatment of aspirin poisoning. Since then, it has become used on a considerable scale. Salient features of the hemodialysis are, it is one of the 3 major replacement therapies, one being the renal transplant, another the peritoneal dialysis, and the second one being the hemodialysis. Toxins most amenable to enhanced elimination by the hemodialysis are those of which have the low molecular mass, less than the 500 Daltons, high water solubility, having the low protein bindings, small volume of distribution, prolonged elimination or having the long half-life, high dialysis clearance relative to the body clearance. These all types of toxins are suited for the hemodialysis. Then the typical composition for the dialysis fluids that is used are it is in the millimole, sodium 140 millimole per liter, potassium, calcium, bicarbonate, magnesium, chloride and glucose are used as a common dialysis fluid. So as you can see in the photograph, the person, one way the blood is being taken out through a pipe, and that goes to a dialyzer, and that dialyzer contains this dialysis fluid, which through the semi-permeable membrane crossing, it dialyzes or cleans the blood, and this blood once get filtered over here. This is dialysis fluid on the half of it. So dialysis fluid also keeps on getting cleaned. That is, here dialysis fluid is getting entered and this is being cleaned and removed. The wastes are getting removed, and the clean blood that passes back through the another line into the vein or the venous circulation. So this is the method employed for the dialysis. Then hemodialysis is useful in cases of the, you may remember the mnemonic BLAST, B-L-A-S-T, barbiturate poisoning, boric acid, bromides, L for lithium compound, A for alcohol, all types of alcohol, methyl, ethyl or isopropyl alcohol, salicylate poisoning, strychnine poisoning, theophylline, thiocyanate. Here the hemodialysis is useful. Hemodialysis is not useful in cases of anticholinergic. Here also A, B, C, D go. Anticholinergics, antidepressants, antihistaminics. Then B for renal alkaloids, benzodiazepines, chloroquines, digitalis, glutathione, opioids. In those conditions, hemodialysis is not useful. You must know it. Then the peritoneal dialysis. Peritoneal dialysis is the concept is same of the dialysis, but here is it is the procedure in which patient's peritoneum is basically used as a semi-permeable membrane across which the toxins in the blood are exchanged. So rather than the outside the dialysis with the taking the blood outside, it is the inside that semi-permeable membrane that is in the our stomach lining, peritoneal lining, that is used over across which the exchange of the fluid occurs and the blood is cleaned. So the basic procedure is that the patient's peritoneal membrane serves as a semi-permeable barrier between the blood in the peritoneal capillaries and the balanced dialysate solution. The later, the dialysate solution is entered into the peritoneal cavity and allowed to dwell for the hours before being drained out and replaced. The osmotic gradient pulls the toxin from the intravascular space of that of the hemolysis. In this case, the same dialysis compounds mixture is used here also. For the adults, around 2 liters of the dialysate fluid is used. For the children of less than 5 years, 200 ml of the dialysate fluid is used. The effectiveness of peritoneal dialysis is 1/4 of the hemodialysis. So only 1/4 of the excretion cleaning of the blood will be happen in one cycle. So we may need to repeat the cycle with the peritoneal dialysis. Then the poisons that are being effectively removed by the peritoneal dialysis includes the alcohol, barbiturates, bromide, chlorohydrate, lithium, mercury, quinidine, salicylate, sodium chlorate and theophylline. These are the compounds which can be effectively removed through the peritoneal dialysis. Then coming to the hemoperfusion. Hemoperfusion is the procedure in which the large volumes of the patient's blood is passed over the adsorbent substance in order to remove the toxic substance. So here, rather than the dialysis mixture, an adsorbent substance is used. So in a similar way of the dialysis, the blood is taken out and it is passed through the adsorbent medium where the filtration of the blood occurs and it is passed again back into the body and after the filtration. So the salient feature is that it is an extracorporeal form of the treatment that is being done outside the body, because the blood is pumped through the device outside the patient's body, whereas this peritoneal dialysis was the intracorporeal method. Sorbents Adsorbents that are most commonly used are the resins and the activated charcoal. Then hemoperfusion is useful even with the highly protein bound substances that have high volume of distribution or are lipid soluble. So this is particularly helpful in this nature of the compounds. Whereas we already learned that the hemodialysis is useful where they have the small volume of distribution, low molecular mass, high water solubility, whereas the hemoperfusion is helpful in cases of high protein bound substance, high volume of distribution and lipid soluble substances. The hemoperfusion commonly used for the acetaminophen, barbiturates, carbamazepine, digitalis, ethchlorvinyl, glutathamide, meprobamate, methaquinone, methotrexate, paraquat, theophylline poisonings. Now the hemofiltration. Hemofiltration or ultrafiltration is the procedure similar to the hemodialysis. That is, the poisons are made to move across the semipermeable membrane. The important difference with respect to the hemodialysis and the hemofiltration is that in the hemofiltration, the diazylate is not used. Rather, the poison is made to pass across the semi-permeable membrane outside the body only. The second major difference is that the positive hydrostatic pressure is created through the pump that causes poison movement through the convection a much faster rate than the diffusion that is followed in case of hemodialysis. So here as we discussed, the poison in the dialysis, here the filter dialyzer fluid is used, whereas in place of dialyzer fluid, in this case this is just a semi-permeable membrane. Across it, according to the method of the crossing across the membrane, this filtration occurs. Just the filtration of the blood is happening, and this is done at a higher, faster pressure than done in the case of hemodialysis. That is the method applied in hemofiltration. Hemofiltration is of two types depending upon the duration of the filtration that takes the time. One is the intermittent filtration, that is it takes 3 to 5 hours of the treatment 3 times a week, and the second method could be the continuous hemofiltration where the therapy is continuously for the 12 to 24 hours of a period. Then depending upon the placement of the cannula, it can be either continuous arteriovenous hemofiltration or continuous veno-venous hemofiltration. So if the cannulas are produced veno-venous, then that is veno-venous continuous filtration, then arteriovenous could be there. So as you can see in this photograph, that blood is injected outside and it is passed through the high pressure and it gets filtered over the semipermeable membrane and it gets to the waist, and then the blood is taken inside the body, and fluid management has to be done according to the reduction in this waste. So this is the basic method applied in case of hemofiltration. The major drawback for hemofiltration is that it is not relatively new technique and its utility is yet not well established. It requires involvement of several specialists from the different backgrounds, and it cannot be performed in a severely hypotensive patient as it causes the loss of the fluid from the body. Elimination rates in case of hemofiltration are much slower as compared to the hemodialysis or hemoperfusion. Now, cardiopulmonary bypass. As the name you can read, cardiopulmonary bypass, here we are bypassing the cardiac system and the pulmonary system. So the blood is filtered by bypassing the heart and the lungs. How this happens is that we are taking the blood before it is getting drained into the heart. So a venous cannula from the vena cavas are applied and the blood will be bypassed outside before it gets into the heart, and then it is again injected back after the blood are supplying to the lungs. So we bypassed both the heart and lungs, and the filtration will go on. We are filtering in between, that we have pump and the oxygenation and filtration is going on in between, and we will again take back to the body. So this is known as the cardiopulmonary bypass. This is basically a drastic step and usually useful in the cases of poisons which are cardiotoxics and which are normally eliminated by the livers. For example, lidocaine and the flecainide, the antiarrhythmic drugs. The blood flow is diverted from the heart and lungs as in the heart surgery. The blood keeps circulating through the other organ, that is liver and the kidney, so the poisons gradually cleared from the system. This procedure essentially buys time until the patient is detoxified. And especially this method is not helpful in case of liver failure, as the liver has major role in detoxifying the poison. Then the exchange transfusion. Exchange transfusion is nothing but simply we are replacing the whole volume of the blood with a fresh blood from the outside or from some other person. That is the exchange transfusion. As you can see in this photographs, this child, some donor blood is being given continuously and his blood is being taken out. So whole body will be replaced with fresh blood. Exchange transfusion is a total blood volume exchange administered in small quantities. It is rarely used in toxin removal. The patient's blood is slowly replaced with the blood from the blood banks. 2 to 4 volumes are exchanged over a period of times so that it gets completely replaced. It is indicated in case of severe methemoglobinemia. In infants, it is very commonly practiced. In cases where the poisons has caused massive hemolysis, there also it will be helpful because blood was no more useful for the person. Poison is when the poison is strongly bound to plasma protein and cannot be removed by hemodialysis, such as in case of thyroxine, iron or theophylline. In those cases also it is helpful. Then the life-threatening injections, it may be of the use. Then poisoning by the therapeutic drugs, here also it may be of help. Then the complications with the exchange transfusion are well known, that the anaphylactic reactions, then the bleeding, hypoglycemia, hypotension, hazard associated with the fresh blood product administration like immune mediated reaction, blood incompatibility, infections, and all these can be the complications of this exchange transfusion. And the last one, the intravenous lipid emulsion. It involves intravenous injection of the fine lipid emulsion. It has been used successfully in the treatment of several lipophilic poisons, especially local anesthetics toxicity. The mechanism of action of this intravenous lipid emulsion is that it produces an additional lipid sink, that is a lipid compartment that we discussed in the distribution of the poisons, in which the lipophilic drugs are sequestered from the plasma. This makes the lipophilic poisons unavailable to the body's tissues. This is mainly useful for the local anesthetics like lidocaine, and other drugs for which the intravenous lipid emulsion is useful is the amiodarone, barbiturates, calcium channel blockers, lipophilic beta blockers, and tricyclic antidepressants. So with this, we have finished the removal of absorbed poisons from the body. In the next class, we will take the antidotes for the management of the poisons. Thank you.